We are now coming into our afternoon session, which I know it has been hotly anticipated for a rematch. Because there was a bit of a slam dunk last year, wasn't there? So, for those of you that didn't attend last year's conference, oh boy, did you miss an event. But there we are. That's another story. But for this year, so I'd like to introduce Professor Alastair Greystoke, who's based at Newcastle, and Dr. Tom Newsom-Davis, who is based at Chelsea and Westminster. Thank you. That was well remembered. I don't need a round of applause for remembering something. Not quite. Anyway, they are going to debate the big issue and the big topic of whether care should be closer to home or out at a regional centre with maybe more experience, okay? So that's what we're going to have a look at today. So can I ask you, at the moment, who travels further to go to a larger centre for their care? Is there anybody in the room? I do. Wow. Oh, okay. So it's not very, it's a handful. Right. Okay. Got a job on your hands, really, haven't you? So without any further ado, I'm going to welcome Dr. Tom Newsom-Davis to the stage.
Afternoon. Thank you very much for inviting me. Thank you very much, Deborah, for making sure this is in Heathrow, which is 20 minutes drive, not Birmingham, which is 3.5 million miles away from sunny Twickenham. Okay, so last year was a huge embarrassment for Ali. It was terrible. But I like to remind him of it every time we meet. So I'm going to try to emulate this. But very quickly, there is a serious point. We're going to talk about regional versus local centralised care. It is just meant to be a bit of fun, not in any way disrespectful to anyone in the audience. And more importantly, if your care is localised or centralised and is what we're arguing against, it's not meant seriously. It's just meant to make us think a little bit about what is possible. So I'm going to talk about centralised care for ALK positive lung cancer. These are my disclosures. So I'm going to give you 6 points. And I'll give you 6 points that are going to explain to you why centralised care is what we should all be doing. And we should not be focusing on localised care for this truly unique condition. The first one is the one behind me. And I don't think anyone in the room here is going to argue with that point. And the reason I say that is that whenever you talk about centralising services, pulling things into bigger centres, thinking about pathways from regions into the hubs perhaps, the first volley of criticisms you get are from doctors. And they're from doctors saying, oh, well, it's not fair. Oh, you know, I won't be able to get to see this interesting condition, this interesting patient group. It's not about them. It's about you guys. It's about the patients. So whenever we think about patient care, how we deliver patient care, how we structure patient care, it's got to be about the patient, not about the doctor. And the NHS is a wonderful organisation, but I think it's fair to say it's largely organised for the convenience of the healthcare workers, not for the convenience of the patients. So that's the first point, which I think even Professor Greystoke is not going to argue against. Maybe he will. He's a professor, I'm not, so, you know, who knows. Interesting fact number 2, you may not know this. Most lung cancer care in the UK is not delivered by lung cancer systemic therapy specialists. Ali Greystoke is a specialist, a world expert in systemic treatment of lung cancer. Systemic treatment, I mean chemotherapy, immunotherapy, targeted therapies. That's what he does. That's what his training is. All the way through, as soon as he finished medical school, he began to specialise. He became more and more specialised in medical oncology. Same as me. That's what we do. That's our interest. That's our focus. But can you believe it? Most lung cancer care in the UK is not delivered by people like us. It's delivered by people whose specialisation is in other kind of things. Or their pure specialisation is in that. What do I mean by that? So this is from something called the Royal College of Radiologists. This is an audit they did in 2020 of all the doctors in the UK and the specialists, oncology specialists in that. And on the left here, you see a group called clinical oncology. And on the middle, you've got medical oncology, and the right is the total, okay? Just to remind you, Ali and I are the guys in the middle. We're the medical oncologists. We specialize in systemic treatment of cancer, chemo, targeted therapies, immunotherapies, those kind of things. On the left are our clinical oncology colleagues. Now, they are also known in other countries radiation oncologists. Now, they don't only do radiation. They do radiation and they do systemic treatments, but they're doing a bit of both. And traditionally, they did much more radiation and much less systemic treatment, and they still have a mix of it. And you can see the numbers that Ali and I are outnumbered 2 to 1 in the UK. Twice as many clinical oncologists as there are medical oncologists. SAS grade is trainee grades as well. But let's just maybe focus on the top 2 lines. So you could say, well, it doesn't matter, Tom. It doesn't matter at all, because just what's a name, yeah? What's a name, whether you're clinical or medical, doesn't really matter. Well, it's true that 1%, and this is from the RCR audit, this is what the doctors themselves reported, 1% of clinical oncologists truly are systemic treatment specialists. They're the absolute exception, and great for them. But 81%, this is what the doctors themselves report, 81% are doing radiotherapy and they're doing chemotherapy and systemic treatment. So they've got trying to do both. Now, it didn't really matter a few years ago when I was young. When I was a trainee, there was 1 or 2 chemos. There was very simple radiation therapy, like a big X-ray, and that was it. Anyone could do all of that. But you guys know more than anyone that has changed completely, hasn't it? Radiotherapy is incredibly complicated. We have traditional radiotherapy, we've got conformal radiotherapy, we've got stereotactic radiotherapy, we've got sexy names like cyberknife and gamma knife and other kinds of knife. So you've got all of that, and then you've got all the huge range of treatments we now have for lung cancer, the chemos, the targeted therapies, the systemic treatments. It's extraordinary. You cannot do all of it well. You can, but I would argue you cannot do all of it well. And I would argue if 81% of your clinical oncologists try and do both, the expression jack of all trades and master of none springs to mind. Not only that, but the recommendations, the Royal College of Radiologists recommendations, is that oncologists should only really be treating, if possible, 2 or fewer tumor types. I just treat lung cancer, very lucky that way. A couple of my colleagues treat 2 treatments, treat 2 tumor types. But through no fault of the oncologists themselves, because of the way NHS is structured, and particularly out in rural areas, district general hospitals, oncologists are being asked to treat more and more tumor types. A third of them are treating 3 or more tumor types. How can you possibly keep abreast of it if you're treating 3 tumor types or 4? I struggle to keep up with lung cancer, and I just treat 1. And you may say, it doesn't really matter, Tom. Who cares? UK does great. I'm afraid to say UK does not do great. This is some fantastic data, international comparison between UK, New Zealand, Denmark, Norway, Australia and Canada. Why those ones? Because they are countries with a very similar demographic, very similar healthcare funding, very similar in lots of different ways. So we're not comparing ourselves to the US, which would be crazy. These are kind of like countries, and we can see that our 5-year survival is unfortunately compared to all of our competitors less good. So it's not that we've got this kind of funny system whereby clinical oncologists are treating a majority of patients and we're doing brilliantly. We have a unique situation where clinical oncologists are treating most patients. Most countries don't do this. Yeah? Most countries, lung cancer is treated by systemic treatment guys like us. But we do have this unusual system, and we're not doing great. So that's my second point, that most lung cancer is not delivered by specialists like Ali and myself. My third one is that centralising cancer care improves outcomes. Now, what I cannot tell you is, here is some data that tells you if you have ALK positive lung cancer, you will do better if you go to a centre or a regional centre, because there's no data to show that. But I've got evidence of the improvement in outcomes in people treated for cancer in centralised centres, okay? So this is one of a number of studies. This was published in 2020, looking at high volume centres, lots of patients coming through them, versus low volume centres. This is a survival curve. So at the top here, on the top of the axis, everyone is alive, and going down through the months from diagnosis, unfortunately, survival goes down as treatments go along. I'd like you to compare the solid lines with the dashed lines. The solid lines are patients who are treated in high volume centres, and the dashed lines are those treated in low volume centres. And you will see that whether someone has metastases or not, the different kinds that don't project terribly well, I'm sorry about that, always the patients in the high volume centres do better than those in the low volume centres. If you're in a centre where not many patients are coming through, it's very difficult for the medical team to get that expertise to treat you properly. All the way through. Now, Ali's going to say, he's a bright guy, he's going to say, hang on, Tom, this is going to include surgical patients, right? And we're not talking about surgery here because largely not always, but a lot of the time we're talking about systemic treatments for advanced stage disease. Well, actually, it bears true for patients with surgery on the left, but also, if you look on the right here, patients with systemic therapy, on chemotherapy. That improvement in survival, the solid lines being higher than the dashed lines, is present all the way through. So I can't tell you specifically for ALK, I won't pretend I can, but I can tell you that if you're treated in a high volume centre, on these kind of data, it's not the only study, survivals are better. Kind of makes sense, doesn't it? Let's imagine you want to get your hip done. Let's say I've got arthritis, I need to get my hip done. I'm in the panacea of a kind of health service where I can get out my direct, my yellow pages, and I can go through which surgeon I want. And I go and see Mr. Bloggs, and Mr. Bloggs does hips. That's all he does. He does 300 hip operations a year. Or I could go to Mr. Jones, or Mr. Jones, and they do one hip operation a year. Who am I going to go for? I'm going to go for the person who does it all day, every day, not the person who has less experience. So, my fourth point, and I need to change this, and I forgot to change when I'm doing my slides, so I'd like to change this. This should say less than 2, not less than 1. Most oncologists see fewer than 1 new ALK patient a year. Fewer than 2, not fewer. Fewer than 2 new ALK patients a year. Now, where did I get that number from? Didn't just make it up. I was quite tempted, but I didn't. Patients diagnosed with lung cancer in the UK, according to the National Lung Cancer Audit 2023. 49% patients diagnosed with advanced lung cancer per year. 2.5% percentage of patients with an ALK fusion. Now, some people say it's 5% have an ALK abnormality. It's true, but most of those are the kind of things we can't target. So 2.5% have an ALK fusion. So I would argue about 400 patients a year are diagnosed with ALK, advanced stage ALK lung cancer every year, at a guess. 1,500 oncologists, right? Told you that in the previous slide. I'm sure you remember that. Sorry, my second slide. Meaning that for each oncologist in the UK, that's about a quarter of a patient every year. Now, I'm not saying that every oncologist in the UK treats lung cancer. They don't. So let's be generous. Let's double that. Let's quadruple that. Well, still only 1 patient a year. Let's go up by 8-fold. Okay, that's 2 patients a year. So maybe somewhere between 1 and 2 patients a year. The other way you can look at it, the top number, number 2, what's that? That's the number of patients that each MDT in the UK would see at most per year, newly diagnosed ALK patients. And I've done that according to the number of MDTs in the UK, according to UK Lung Cancer Collaborative report 2 years ago. So your standard MDT sitting there, going through the patients, they might see 1 or 2 patients a year. Is that a great way of doing it? Is that great that you're in a centre where just the numbers coming through are not big enough and great enough to give you the experience to know what you're doing? I'd argue not. I'd also argue my clicker's broken. There we go. The management of ALK lung cancer is really complicated. Now, anyone can read a guideline, right? Anyone can download the PDF and go, oh, yeah, well, you just follow the arrows and off we go. And to a degree, when you're starting out, once you know what it is, assuming someone's actually bothered to do the test or do it properly, to a degree, that's right. I'm sure you've all had conversations with a relevant oncologist about choice of first-line ALK inhibitor. But actually, these that happen to be the American NCCN guidelines, I could put up all sorts of them, they get quite complicated. So, yeah, okay, maybe people can do that. But I would argue this is a really nuanced, complicated disease. I would argue that if you do it well and with the best information and the best evidence, I know that Ali would do, saying that just to undermine him slightly. If you had his expertise, you get fabulous care. But if someone isn't quite up to date, if they haven't quite known the recent data because they're actually not a systemic treatment specialist, they're actually treating 3 or 4 different tumor types, they're actually trying to do some radiotherapy at the same time, and anyway, they only see 1 or 2 outpatients a year. Is that a great way of doing it? I would argue not. Finally, I would say that centralised treatment does not preclude local care. So we might say, this is a great idea, Tom. I'm completely convinced, as I'm sure you are, I'm sure you all are, that centralising it's the way forward because localised care is not going to work. You say that's just beyond the ability of the NHS. NHS can't do that. This is an organisation that struggles to be responsive to patients' needs. There's no such example of a centralised system for treating a rare tumour type. But actually, there is. My alma mater, so I did my medical oncology training at Charing Cross. Very nice Henry Moore statue there in the front. I actually think it's a replica. The original got nicked, I'm told, but anyway. Charing Cross has run an amazing service for something called GTD, gestational trophoblastic disease. You may have heard of molar pregnancies. So molar pregnancies are on a range of malignancies or tumours affecting women who are pregnant, ranging from molar pregnancies to a very aggressive, very treatable cancer called choriocarcinoma. And since the early 80s, this has been a nationalised centre. If you are diagnosed anywhere in the UK, you are either flown in, and that includes from Northern Ireland, you're either flown in to Charing Cross, or even UK, you can come air ambulance, whatever, or your case is monitored centrally from Charing Cross. And the really high-risk patients, yes, they do indeed have their inpatient chemotherapy at Charing Cross, but there's this huge programme of coordinating the care of these patients, usually at home, usually through their local team, and it works brilliantly. So my argument is, actually what we shouldn't be doing is saying to people, right, you've all got to move down to, I don't know, London or wherever it might be, Christie, wherever it may be, and we'll have one centre. I don't think that's the answer. But I do think there's an answer to saying we should have a small number of highly specialised, regional, let's say 3, argument's sake, ALK MDTs, where anyone can send their own case or their doctors can send their patients' cases for a discussion. Go through the information and say, okay, come up and see us, we'll go through this, and then work with the local team to say, actually, I think you should do a re-biopsy. Actually, don't switch treatments. Have you thought about stereotactic radiotherapy? Actually, do you know what? Do you know there's a trial about this? Because I think if we do that, if we use that centralised bit, you can have centralised expertise of people who really know what they're talking about, people like Ali, and get that expertise out to everyone. And if we just allow the current situation to be where, if you're lucky, that's what you're doing, but actually you might be out somewhere in the sticks in someone who's not quite up to date, then I don't think that's a great way forward. And those are my 6 arguments. Thank you very much.
Dear, dear, dear me. Flattery won't get you anywhere. Maybe. Right. So I'm going to give the case for local delivery of care. So first off, my disclosures slides. But again, just to highlight that these are the purposes for debate. So a couple of things. I'm afraid I have to admit to being a centralised carer. So I think, sorry. I think I've certainly looked after patients day in, day out from Lincoln. And Tom, this is outside London. It is quite a long way from Lincoln to Newcastle. And I have given second opinions to patients in Southwest England, Wales, Ireland. So actually the important point is, I know there's a lot in the media at the moment about second opinions. Everyone in the NHS does have a right to a second opinion. They don't need to make a law of it, okay? You're perfectly in your right. And maybe in the discussions on see if people want to talk about what you should try and get out of a second opinion, that may be worthwhile. The other thing to say is that although I do deliver centralised care, I actually work as part of a group of oncologists. We all work together very closely. We cover a huge geographical area, as I'll show you. There's 13 of us, okay? We don't need a specialized MDT, okay? We speak we speak once or twice a week. We talk about difficult questions. We can bat things off each other. We're not sat in a dark room talking about 30 patients who we have never met, okay? Do you want somebody in a dark room in London making decisions about your care in Newcastle? I don't. Right, here we go. Tom says it's difficult. No, it's not. It's easy. Unfortunately, it is easy. Certainly, as he did admit it is easy at the beginning. I would say it's easy at the beginning and the middle, and probably towards the end, but you need different people at the end, as we'll come on to. So we're bound by NICE. So NICE tell us what we can do, okay? And they've given us access to 4 different tablets, but nobody in the UK now is using crizotinib, I'm pleased to hear, first line, or ceritinib, although there are some people still on ceritinib as legacy. I heard earlier there's one in the room. And then actually, it's pretty easy because everyone, when they progress, and we can talk about how you work that out, is switching to lorlatinib. Okay, I've never had a patient who I've said, okay, the present tablet is not working quite so well for you. Would you like another tablet, or would you like some chemo? I've never had anyone go, oh, I want a chemo, please. So the nuances only start to come in later down the line when we're unfortunately starting to run out of some of our better options. Now, I did try to keep this to the E's, so E for easy. It did get a bit of a struggle later on, I'm afraid. Extended treatment, okay? So Tom thankfully showed earlier some of these survival curves. So you can use them for when patients are unfortunately dying, but these are actually showing what's called progression-free survival. So these are patients whose cancer is under control, and this is ALK data. So this is alectinib, and in the bottom you can see the patients on crizotinib, where unfortunately it stops working after about a year, and you can see the patients on alectinib, where many of it, well, over half, it was still working for them at 3 years. And some even longer. You can look at that straight line. Some of these patients on 6, 7, and we've heard this in the room today, will be on their first-line tablet 6, 7 years. Now, do you really want to be driving Centralised into the Marsden to spend your hour sat in a waiting room to see the professor pop out, clasp your hand for 5 seconds and say, yeah, you're doing really well in the elective, go away, come back in another month's time for your tablets? Do you want to be doing that for 6, 7, 8 years? Do you need that? It's easy. And that's the same for brigatinib. Again, about 50% of patients, 3 years. I have many patients, including some under centralized care, who unfortunately do drive up and see me, and I give them a month of tablets, and off you go again. I try to give them 2 months of tablets, but I'm always a bit reluctant to do more than that. I have occasionally had my arm twisted to 3. Okay, Tom lives in London. That is not London. Well recognized. So, I arrived in London today. I got off the train at King's Cross. I walked down to the tube. There were 4 tubes in 10 minutes heading towards Heathrow Airport. Okay? This is Newcastle. And actually, that first bit is where I live in the lovely Northumberland countryside. I'm very lucky. Surrounded by green, I escaped London. And there is the Freeman Hospital, which is the quaternary centre for North East England. Okay, so we cover, for sort of non-specialist things, about 1.5 patients over a huge geographical area. For trials, I go, and so that's up to Berwick, across to Whitehaven, which is a 2.5-hour drive, down to sort of Middlesbrough. I'll explain where all these places are later, Tom, to you. And for trials, even more. So, I have patients who come over from Northern Ireland to see me, patients from Scotland, et cetera, et cetera. So, yeah, that's where I live. It's very pretty. I'm also very lucky, so I live in a nice little commuter village. I have a bus stop outside my house, and I have a train station 5 minutes down the road. That is on the main line between Carlisle and Newcastle. It's 15 miles. There is 1 train an hour. I put into Google how long it would take me to get by public transport to the Freeman, and you can see almost 2 hours. Okay, well, you can say, well, I can drive a car. Rishi Sunak says, I need my car. It's about 25-minute, half-an-hour drive when there's no traffic. So people could do that. And actually, I live quite close. I live much closer to the hospital than many of my patients do. But unfortunately, we know that ALK lung cancer patients will get brain metastasis. So this is a very recent meta-analysis that shows at presentation almost a quarter, maybe quarter to fifth of, no, it's even more than that, isn't it? Sorry, it is, yeah, sorry, it's a third, 30%. Got my numbers wrong, sorry. About a third of patients with ALK lung cancer, if you look carefully enough, properly with MRI scans, about a third of them will have some lung disease. some brain disease. And we also know that in those that do not, about 1 in 8 per year will develop a new brain metastasis. So by the time they come to the end of their cancer treatment, almost half of ALK patients will have brain disease. It's important we manage that correctly, but unfortunately we live in a Victorian country and the DVLA are utter rubbish. They will take away your driving license. You can live in deepest, darkest Northumberland. How are you going to get to the hospital then? A taxi from my place is still only 20, 30 minutes drive. If you can get one, because you don't want to go out to the countryside, 60, 70 quid. You're going to take that both ways? Or is one of your family members going to take you from work? It's not necessary. I've got a lovely little village hospital, about 5-10 minutes down the road, which you could go to instead. Get your tablets, it's easy. And some of my patients do that. And I look after them. I thought, Tom, you missed a trick here, Tom. I thought you were going to talk about video calls, telephone calls, so you don't actually need to come see your centralised person. Yeah. Doctors don't like them. I don't like them. It's rubbish. Patients don't like them. So that's a really nice recent paper from the Christie. On the left, some quotes from it for patients who had telephone calls during COVID. And I'll leave you to read some of the quotes, but I think we all realise that there is a real nuance to being face-to-face, even over a video call. The ability for somebody to reach out and just touch you or to be there afterwards. The ability of a lung specialist nurse to be there when you've got unexpected bad news. So patients definitely prefer face-to-face. Okay, 3 E's. So emergency. So I live out 50 miles outside in the countryside. If I become unwell, and my wife calls an ambulance 999, turn up eventually, it will take me to Cramlington Hospital, which is 15 miles north of the Freeman Hospital. It is not part of my trust. My scans will not be on there. My records will not be on there. Even worse, if I'm going down to the Marsden, and I fall unwell, they will have to try and get somebody in the Marsden. And I've had this happen recently with one of my patients. He went down to London and became unwell. They did a scan, told him utter rubbish because he did not have his last scans to compare to. Okay? And yes, we're supposed to be in the National Health Service, but we all know it isn't. So actually, if you're in your local hospital, that will be where you go for, and then they know who the oncologist is, and they can pick up the telephone to them. If they'll have the scans, and if they want advice, they can say, NHS thrives on personal relationships. They know me, they can pick up the phone and say, I've got your patient in who's really unwell. What do you want me to do with them? And even better, I might be able to wander in on my way home from work and, if they're on the medical ward, and I've done this, and said, yeah, how are you getting on? Give the medical team some advice. Education. So we work, so I'm an oncologist. I work as part of a lung team. Okay, so I work with the chest doctors, I work with the radiologist, I work with the pathologist, I work with the lung nurses. It is important, so one of the things 10 years ago when Tom and I first started doing what we do, there was huge amounts of nihilism around lung cancer, huge amounts. We only had platinum chemotherapy. It was like, well, you can go see the oncologist, but what's the point? And now we will be saying, we hope they have an EGFR mutation or an ALK fusion or a RET fusion, because they know they have seen their patients, some of whom have been really unwell, and they've come along and I've run into the ITU, and I have done this. I have run into ITU and put the ALK inhibitor, patient still asleep, down in the nasogastric tube, and have seen the patient get much better. So the ability to educate the wider community and not just be sat in our ivory towers is really important. And also educating our junior doctors coming through. Not just the ones that are going to the specialist centres, because my junior doctor today might be treating you in 2-3 years' time. So don't you want him seeing, every junior doctor, every oncologist coming through, even including the clinical oncologist, God help them, learning about lung cancer and its treatment. And yeah, experience is important, but we can share experience, and you want your oncologist to be experienced as well, okay? But, so again, say you're coming to a centralised centre for your tablets. Are you going to come there for your radiotherapy? You're going to be, you're going to have 2 weeks of radiotherapy and a planning scan. So you're going to make all those trips down day after day to the radiotherapy centre. So we need global experience for everything. The other thing in terms of experience is, yes, you may go to your centralised centre. So, I have patients under my care, but unfortunately I'm a busy man. You saw all my disclosures and all the other jobs I have. And I come to conferences like this, and they're not all on Saturdays. So maybe 50% of the time, I won't be in clinic. So you just get to see a snotty fellow who doesn't know what they're doing anyway. So you've come all the way, maybe not for a very good experience, and I've certainly referred patients down to esteemed centres who have not got very good referrals back. And the last thing is just in terms of capacity. So, you know, again, the NHS is under huge strain at the moment. We're struggling to get scans done. We're struggling to get them reported. In our hospital, we have 3 MRI scanners, okay? And that's to cover that population of 1.5, 3 million people, including specialist services like neurosurgery. So actually, for me to get an urgent MRI is really difficult. If you live down the road in Durham, and unfortunately you're a young patient who's just been diagnosed with lung cancer, and I call up the radiologist, or get the lung nurse to call up the radiologist and say, look, this is the situation, I need an urgent MRI. It's such an extraordinary case, you'll get your scan straight away. And then we also spread out the load so that not all the patients are coming into Newcastle and gumming up the system with the scans. Okay, so actually, it means it is doing it for the National Health Service. I'm sorry, but it actually means the National Health Service can work better for all of us. Okay. Lastly, and this is a sad bit, you know, so I've been working in Newcastle for 10 years. I have some patients who are still with me, who were there at the beginning. So they were diagnosed back in 2013 when I was first there. Equally, unfortunately, I have lost a number of patients who I've made relationships with over the year. And this is the experience from Colorado, which said, you know, average life expectancy is 7 years. In the UK, we're coming up towards that now with better access to treatments. But unfortunately, at some points, people do start to run out of treatment options, they become less well. And I sometimes have to have very difficult conversations with people and say, look, I'm running out of treatment options for you now. I'm still going to look after you, but I don't have the tablets left. I don't have the chemotherapy. But the ability then to ensure that I can set them up in their local environment. Most of them want to stay at home. They don't want to be in the hospital. I know the physiotherapists. We have an outpatient therapy service. So we have a physiotherapist, an occupational therapist, and a social worker who work with me. Lung cancer nurses work with me. I can deliver all that to the patients who work in Newcastle. They've got all the links in. They can speak to the GPs. They can get oxygen. They can get beds in 24 hours. If it's a patient an hour and a half away, they don't have those links. I don't have anyone to call. I have to try and speak to the GP. And professors do not have a hotline to your GP. You end up with exactly the same receptionist who's just as grumpy. Okay? So local care allows us to build those relationships, to get to know people who are going to look after us all the way through. And lastly, again, he didn't bring this up. Well, he sort of brought this up. You don't need centralised care to get on trials, okay? We have a number of things. So you can go on CRUK and look at trials. People say, well, you know, they don't do the really early, exciting trials like Anna's going to talk to you later on about Newville and stuff. I think that's on there. But actually, at the bottom left, there's a new internet search engine, which is run by CRUK as well. Every single oncologist in the UK has access to this now. And if not, they can get it. And that's completely up to date, and it's got all my little private studies of new drugs coming through. It is private to oncologists because it's also got my mobile phone number on, so that and my email, so that if the oncologist, you're in Lincoln, your oncologist looks at your scan and says, oh, it's not right, he can drop me an email straight away and say, look, do you have a slot? Okay, so he doesn't need to go searching around, so that's why it's private. But equally, there's so many groups out there, there's a number of people in this room who are really research active, tracking the trials for you, going out to conferences, you all know who you are, who are keeping you up to speed on what trials are, okay? And you can always ask to be referred for a trial. Sometimes you may not be suitable for that trial, and I suspect Anna will talk to you about it a little bit more about that later on. So actually, I came up with exactly the same thing as Tom. My last slide is the same as his first. Patient experience is key, but you get that better with local delivery of service. Right.
Well, I won, so I'm off.
I don't think it's going to be 90% this time, I hope.
I don't think it's going to be a slam dunk. Anyway, so we do now need to vote as to how we're feeling. So are we going with centralised care? I'm being pushed over this way. Are we going over centralised care or are we going local care? So, those in favour of Tom's argument, put your hands up, please.
Oh dear.
Free coffee, anyone who puts their hand up. And cake.
Okay, hang on. Those in favour of Alastair's argument.
Oh, it's a bit closer this year. Oh.
Ooh,
I
very
think Ali wins it.
close.
Should we call it 50-50 and
I'm not sure. It is, yeah. So,
There's only going to be one winner there. It's not going to be me.
well, gentlemen, I think we're going to have to call this one a draw.
third time
So-
lucky for
An
me?
honourable draw.
So I think we might have to see them back next year for another debate. But while we've got the two of them on the stage, and they do know a little bit about ALK, then it's a great opportunity for us to ask any questions that we've got. And I'm sure we have questions in the room. So does anyone have any questions they want to ask? There's one over here. Lisa does. There we are. So we'll just get the roving mic round.
Hiya. I just wanted to ask, just going back to Tom's slide on the 5-year survival rates and how UK was, quite low compared to the other countries. Can you expand on, your thoughts on what's driving that?
Yeah, absolutely.
Any other, factors, like do they do anything different in terms of, earlier diagnosis?
Absolutely. I was behaved very badly, and I alluded to the fact that was all due to my clinical oncology friends, which is not the case. So it's a really complicated thing, and people write books about this. It is multifactorial. There are lots of things which underlie it. It is to do with a little bit to do with health of the nation, how much we eat, our weight, our smoking, other issues as well. There are healthier nations in the UK and there are unhealthier nations in the UK. It is to do with accessing healthcare. And one of the difficulties which may ring true for a lot of people, and this is not a criticism of my GP colleague friends, is it's very difficult to access healthcare, particularly through primary care. And the NHS is a very cost-effective system because the GPs are fantastic gatekeepers. But there is an issue, which is it is very difficult to go and see a specialist lung physician unless you have a GP referral. And that gatekeeper role is probably part of an issue. What I don't think it is access to drugs, because actually we have the same access as any of our colleagues across the world, with a possible exception of America, where things are used very much without evidence base. Compared to our European friends, identical treatment. And that wasn't the case. And when I started as an oncologist, which was a couple of years before Ali, sadly, because I'm older, the NICE guidelines were something like 25 pages long. They're now 230 pages long. So it didn't used to be like that. So I don't think it's drugs, but I think it's to do with the health of our nation. I think it's to do with how we access healthcare. And I think it's to do with an increase in late diagnosis. And that's, again, to do with we struggle as all of us to access healthcare when we need it.
Yeah, no, completely. We know still about coming up towards a quarter to a half of patients will present with their lung cancer through A&E. And actually that's probably higher for the non-smoking related lung cancers because the GPs don't think about it. And that's actually one of the worst prognostic factors, is actually presenting as an emergency. And equally, people have looked at this, and on average, the standard lung cancer patient will often see their GP 3, 4, 5 times before. And again, I don't think I would never be a GP. I think their job is far too difficult, and I think they have been set up by the government as gatekeepers, which is detrimental to both their job and our job, quite frankly. We probably need a complete reworking of our model. That was set up when the NHS was set up with that primary care, secondary care, and it probably doesn't work for today's medicine.
But it won't change because it's too politically difficult.
Yeah.
So nothing will ever change, because any party that ultimately wants to rechange or refund the NHS structure is going to be voted out of power. So it will just continue.
Yeah.
Sorry.
Right, I've got another question. Andy?
Related to the debate, and I think you both touched on this, how much do you cooperate and collaborate with each other and across other oncologists? Because I think for me, where I work, there's almost a culture of non-collaboration. But what I've seen and heard from my own oncologists, actually, there is a big culture of collaborations. Maybe just expand on that, which I know you're giving polar opposites in the debate, but there's probably somewhere in the middle.
So we do try to set up networks, and one of the things we've tried to do for ALK is to set up mentorships, because as Tom said, there may be some oncologists who only see 1 or 2 a year. So what we've tried to do is to make sure, most places will be working within a sort of hub and spoke model like I do in Newcastle, so we cover a big area and there'll be an expert of some description. But so I often give advice to oncologists in Wales, Scotland, as well. So we try and build like a mentor or a buddy system. It does rely on personal relationships, unfortunately, which is not great, but they are there. You know, I think certainly the lung oncologists, we've always been quite a close-knit community. Some of you may have seen some stuff on social media around our conference, which probably shouldn't have been on there, but we do get on very well together. We're quite happy to talk to each other, to make fun of each other. And that actually leads to a very healthy working relationship, I think, for both us and hopefully for our patients as well.
Yeah, I'd absolutely agree. I think the lung oncology community, from the healthcare professional point of view, is very close. It's quite a small group, and people do get on well. I really don't know of any situations where there are very difficult people who don't want to collaborate. I think what's more difficult and what's challenging, which we struggle through BTOC, so BTOC is British Thoracic Oncology Group. This is the healthcare group for doctors, nurses, any healthcare professional involved in looking after people with thoracic malignancies. The difficulty we have in our education is reaching people when we don't know who they are. So we have fantastic representation from Newcastle, we have fantastic representation from Manchester. We've got amazing colleagues throughout the country who are so helpful and so collaborative. But then there's these people we don't quite know who they are, smaller places, and it's difficult to get hold of them. But I think, I mean, the great advantage of NHS is there is no competition. If you're to work in the US, there's huge competition because it's all money follows the patient. And so people are very protective of their patients. They don't want your patient going to see Dr. Bloggs because Dr. Bloggs might take their patient. I'd be delighted if someone under my care went to see Ali because they get a fantastic opinion. So I think the NHS is really powerful that way. And I think people do collaborate, but we should do more.
Question?
Cool.
I wanted to ask if you had any opinion on the use of off-label drugs, which in fact I've only just noticed recently, things like the Care Oncology Clinic, who are adding in things like metformin and doxycycline, whatever. Is there any view on that at the moment?
Yes. Strong views. So in terms of some of those drugs that have been suggested to give extra benefits, a lot of it is a lot like what we're hearing in the diet thing before. You need to look at what the evidence is. And actually, for a lot of them, there's not a huge amount of evidence. The most number of studies have been done with metformin, some of which have been positive, most of which have been negative, and most of which have been small, and probably not very well done. I have issues with the care oncology setup, because for me, again, you know, as I said in the dietary lecture, if you're having to pay for something, always do a little bit, and they set it up as if it's research. To me, clinical research, you should not be paying for clinical research in this country, okay? And the other thing to say is that we do have a, so in terms of off-label drugs, so we now have a study through Cancer Research UK that's just starting to look at the issue of using off-label drugs, maybe within label, working with NHS England. So it's not so good for lung cancer because actually we've got quite a lot of benefits, quite a lot of the drugs already available. But say, for example, you now are found with an ALK positive other cancer type, so a gallbladder cancer. Within that study, you can now get alectinib within an NHS-approved study that's actually hopefully going to lead forward to funding for rare cancers like that. So I think there are ways of doing it. I'd quite like that study to look at progression on, you know, on, for example, alatinib and adding in another tablet. It's not up to that point yet, but I think we have structures in this country that we're quite good at doing studies like that. I don't like the care oncology model, and I'm very happy to say that, and I've said that to my patients.
Yeah, I have a lot of sympathy for wanting to find things and do things differently to what Ali and I can prescribe in clinic. And I absolutely get that treatment of any illness is more than just dishing out tablets. And there are alternative and complementary approaches one might take, and by and large, I wholly support that. I have the same opinion of care oncology in that approach as Ali does. I don't think anyone should ever pay for that. I think it should always, if one is going to explore those things, that should be in the context of a proper study. So yeah, great to do alternative and complementary things, so long as you know that those things aren't going to clash with the medicines you're taking. Be very careful of anyone who asks you for money to give out non-licensed drugs.
Okay. Question here.
I wanted to ask about primary care.
Yeah.
And you mentioned, for example, doctors or primary care being gatekeepers. I understand the point about the health of the nation. I think that's significant in any terminal illness specifically. But what I wanted to ask about more poignantly was, how do young people, and I mean by definition under 55, get to see you earlier?
Yeah.
And is there a communication between yourselves and the primary care to make that path easier, as well as those who are over 55?
Yeah. I think it's Tom, I'm going first, sorry. Dominic, you got to go first all the time before, so I think it's a really good question, and I think it is difficult, and I think young patients aren't necessarily used to using that GP system and thinking about how it works. So short of ripping up the whole system, I think there are some things that we can start to look at. Ways of working. So I do try to work with primary care, but again, it's quite difficult. It's difficult to reach out. They're very busy people. They will only see one new lung cancer a year, never mind one ALK lung cancer a year. So they don't want to hear from some professor in Newcastle who's going to tell them about ALK lung cancers. It's not of interest to them. But we do talk to them about lung cancer and trying to get equitable access. We do publicity campaigns pointing out that non-smoking related lung cancer is now the 7th most common cancer in the UK. And there's various things that the charity is doing as well to do that. And then there's going to be, using things like new technologies coming forward. So some of you may be aware that there's blood-borne screening studies coming forward. There's also what are called new diagnostic centres coming forward for patients that have difficult symptoms. But I'm not sure I've got the right answer for you, so I'm going to pass you over to Tom, who's going to tell you.
That's a brilliant question. So this is a problem across the world. This is not an NHS problem. So every single country has the same issue. The trouble is that the programs, most of medicine is built on pattern recognition. If someone is a little bit older, they smoked a lot, they have a chronic cough, X-ray, refer to respiratory physicians. If you're younger and you don't smoke, you fall through the gap. How do we remedy that? We remedy that through education, and we remedy that through education from ALK Positive, from Roy Castle, from BLF. The message has to be, if you have lungs, you can get lung cancer. And we just have to get that through so that GPs recognise that. We have to allow the GPs ready access to secondary care, because it's still quite difficult for them. It's better than it used to be, but we've got to be able to say to them, either, yes, just refer your patient up, we'll sort them out, or something which has now come in recently called advice and guidance, where they can email a respiratory physician and say, I've got this 40-year-old guy, he hasn't smoked, but do you know what, he's got the symptoms of lung cancer, and the respiratory physician is going to go, oh my God, get him up here. And they can do that literally by email, so that's a good start. And then there's been an introduction of things called rapid diagnostic clinics, or something called vague symptoms clinics, which we actually, if I'm blowing my own trumpet, pioneered down at Chelsea about 10 years ago, saying to GPs, if you've got someone and they don't really fit into your classic diagnostic, but do you know what, you're worried and you think they might have cancer, send them to us anyway. Because actually when the GP says, I don't know what it is, but I'm worried, that's a really, really important thing. And I think trying to do that is the most we can do. And I guess the last thing we need to do is we need to empower patients to say, if you've seen your GP and they haven't listened to you, we've got to find a way of allowing all of us to be able to somehow get another GP opinion, or maybe go straight to hospital to say, I'm not happy. I need to have this symptom addressed.
Without breaking the NHS. And the problem is, as I said, so I said earlier, you can get a second opinion. I agree with you. It's quite difficult to do in GP land, and they get to see the same patients time and time again. It must be very wearing for them because, some of these patients will be challenging to deliver to do, and they get 10 minutes or whatever it is,
And it really is an international problem. I spoke to one of my colleagues in Spain a couple of weeks ago, and he's saying exactly the same thing. He works out of Madrid. Same thing, same problems, same challenges.
Okay, thank you. Question over here.
Speaking to people at the conference and following the Facebook ALK Positive group, there definitely seems to be quite a lot of variation in the care provided to patients with ALK positive lung cancer. So I wonder specifically for patients that are receiving care at district general hospitals and non-specialist centres, what would your advice be if they feel they may not be receiving best care, other than seeking a second opinion or presenting them with a paper?
So I wouldn't necessarily present them with the paper. No. So I love it when patients bring me papers because I often learn stuff, and I've often learned about studies as well. But I suspect some oncologists are not like that, and that can bring down the barriers. And again, I think sometimes asking for second opinions can, although it shouldn't. I think it's very reasonable to say, look, I've been on the UK ALK group and a patient down the road had this treated in a slightly different manner. Have you thought about it? And sometimes they will have done it and, and discussed it with a couple of colleagues and said, actually, no, I've discussed it with them and, they can't give radiotherapy to that particular area because it's too difficult. I didn't bother you with it. So that's fine. It gets your weight off your mind. Sometimes they say, oh, I didn't actually think of that. It's a good idea. I'll explore that for you. Sometimes you may get to the point where, you've asked them and you're still not happy. And in that situation, I would ask for a second opinion. Okay? And I said I would say how to ask for a second opinion. So if you want a second opinion, ask for it in a nice manner. Know who you want the second opinion from, ideally. But the most important thing is know what you want from that second opinion. Okay, I get asked for lots of second opinions. I get you asked for that. Okay, and the first thing I ask is, what do you want? And I'm quite happy to go through the whole, but if that's 5-6 years of treatment, it's going to take me a while, and I may not be able to comment on it. So think about, do I want my second opinion on where I am now? Or do I want my second opinion about what happened to me 4 or 5 years ago? Because it might be somebody else that I want to talk to about that.
I agree with all of that. The last thing to say is I think that's why this kind of organisation is so important.
Yes.
Because when you've got patient forums, when you can look at what other people are doing, you can educate yourself and go back to your oncologist and say, well, hang on, a friend of mine up the road is having this, why aren't I? I mean, that to me is the absolute reason, one of the main reasons why patient forums are so important, whether they're UK-based or international.
Do be aware that some of the stuff that goes on in America is a little bit crazy. So some of it, I think, is forward-thinking. It's probably what we'll be doing in 5-10 years' time. Yeah. Some of it's a little bit crazy.
It's a really important. In fact, we were discussing this on a conversation we had a couple of days ago. That this side of the Atlantic, by which I mean all of Europe and most of the rest of what we would see as the developed world in terms of medicine, will use evidence-based medicine. That you will use a treatment when you can point to a piece of research saying it's beneficial. In the States, it's not really done like that. They'll just go off piece. Now, there's some great reasons why that might be a great thing, and there's lots of reasons why it may not be a great thing. So that's why you'll see that separation, and that's very much a long-term cultural difference between the States and the UK. And I think you're absolutely right. What happens there is often different, and that may be good, but it may equally be quite bad.
And if you come to your oncologist and say, look, I'm already taking this tablet, and I want you to prescribe this other tablet. So people do this sometimes. You see in America, so you're on lorlatinib, and you found a RET fusion, and they want you to prescribe selpercatinib. Now, even if I wanted to do it, even if the money was there, there's no way. So when I prescribe something, not only do I have to tick lots of boxes, you guys aren't aware of that, putting my GMC registration online saying the patient meets these characteristics, which sometimes they don't always do. But anyway, I have to tick all these boxes. But also, every time I do a prescription on you, on your NHS number, that gets downloaded to a computer in NHS England, okay? It's what's called SACT. So you may hear people talking about SACT. So if I then start trying to add something in, it's not like you take one prescription to one pharmacy and one prescription to another pharmacy. These drugs are so expensive that the NHS have their eyes on them. So, you know, I'm not even sure, even if I prescribed the lorlatinib and Tom prescribed the selpercatinib, NHS England would know about it because the NHS numbers. So, yeah, we're being watched all the time because they know we're chancers.
Any other questions? Yes, sorry.
I think you mentioned blood biopsies.
Yep.
What's your view of blood biopsies at initial diagnosis whilst being maintained on a TKI and then in progression?
At this moment, it's probably a nice to have rather than guiding treatment, partly because I did say it was easy, and we don't have the ability to add in those extra drugs, even within trials, if I would like to do so. You know, that's my, if somebody wants to talk to me afterwards, I think for the next year, this is what we need to do. We need to get the UK doing something like that. Circulating free DNA, so I do a lot of time, I'm running the NHS England pilot on patients first presenting with lung cancer to try and access circulating free DNA, get a rapid diagnosis. If you are on a TKI, often you won't even actually pick up any tumour DNA, particularly if it's active in the brain. And even if it is, it may not lead to another option. The one thing where it may change management outside of a trial is that very occasionally cancer types will change under treatment. Okay, so most people who have ALK lung cancer will have lung adenocarcinoma. Sometimes it will change to small cell chemotherapy type cancer or squamous cell cancer. And in that situation, even if we did have lorlatinib, we might not want to give you that. That might be the one we say, actually, we want to give you chemotherapy. You can sometimes pick up signals that that's happening on the blood, but that's what you do need a biopsy. But that's what, about 5-10% probably? So about 1 in 10, 1 in 20 patients who have the biopsy, you may change their management. And unfortunately, that is one where your oncologist that's bad news if your cancer is starting to change to a different type. They become very difficult to treat.
Nothing to add. I agree.
I think there's another question down there, and then Sean,
Hi.
one at the back once, Mike.
Hi, I just had a question on progression. It seems that when most of us these days, if you're newly or newer diagnosed, you're put on a second-gen TKI, and at progression, you're just given the next line treatment. Is there any interest in doing tumor testing? Because it just feels like, what if something else is going wrong? It's more so anecdotally that I see in the support group sometimes people are just put on their lorlatinib next and say, well, if it doesn't work, we'll know in 8 weeks and then we'll see what's going on. It just feels like we've just lost 8 weeks there if it's not going to work. And then your cancer is even more out of control.
You can go first on this one.
I think that's a great reason. And when Ali was giving his answer before, that's kind of what I was thinking about, which is a biopsy is a very nice thing to have. We go to conferences and that's what everyone says they do, although in reality that doesn't really match real-world experience because that's largely from small, rarefied centres with lots of resources. I think if I can get a biopsy, I think if I've got time to do that and I've got time to get the molecular analysis back, which bear in mind is going to take at least a month from let's do a biopsy to actually having an idea what the result is, then I think it's a useful thing to have. Because there are some situations you get a result back and it either says don't use lorlatinib or it says I don't think it's going to work very well or very long. A more difficult decision then is does that actually mean you don't use lorlatinib and you go straight for example, chemotherapy, because then maybe you've missed out this chance. That's more difficult. So I think if you've got time, and if it's a procedure which is low risk and is not going to be too unpleasant, I think it's a useful thing. And I think whenever we change any treatment in any cancer, but particularly with ALK, I think we need to just reflect, are we doing the right thing changing the treatment? Is there anything else we can do apart from our knee-jerk going down the NICE pathway? Because that NICE algorithm is great, and I think there are good things that NICE put those out because we want to say to all of our colleagues, these are drugs that are available. But what they don't say, that kind of cascade is, what is the right thing to do? It tells you what is possible and what the options are, but it doesn't tell you what the right thing is to do.
Okay, thank you. I think there's a question back.
Hi, yeah. Do we know how many people are missing from the room? And is the health service doing something about that?
Yes. So the answer to that is we've got some ideas. It's slightly different. I know Deborah and the team are doing some work on that. I think the problem is that Tom talked about the 5%, the 2.5%. In Newcastle, it's 1.3% because of our different demographic, more smokers and stuff. So it is difficult to get, but there are people who should be in this room who aren't. One of the things that the NHS is quite good at is when we start to audit data is actually starting to, is making sure that it actually happens and exploring why there's discrepancies. And up to recently, capturing ALK status has not really been on there. EGFR was checked and it became a metric. I'm trying to encourage BTOG and the Royal College that not only EGFR and ALK, but actually having the full, so there's now 8 genes that should be checked by all oncologists when their patient's first diagnosed, that should be a key metric of a good functioning lung cancer service. But until we start to capture that data, we won't know how many we're missing. And that's, to me, is the number one thing we can do. I can set up my fancy cfDNA pilots, but until we start to capture that and say, look, having those 8 genes is a sign that your lung MDT, I talked about earlier, so the 30 people in the room, that's a proper functioning MDT if you get 85 or 90% of people getting all those 8 genes. You won't get 100% because it's impossible.
Yeah, I think that in all of medicine, not just ALK, not just lung cancer, not just oncology, I think all of medicine, patient advocacy groups, patient support groups are overrepresented. They're biased towards middle to higher socioeconomic status, higher educational level, more Caucasian. There's an underrepresentation of certain racial groups, underrepresentation of people with low educational achievement. So I think it's always a problem. I think it's always really hard to reach everyone. And the sad truth is the people who need it the most are often the people who aren't in the room. And Deborah's done a lot of work trying to say, well, we think the numbers are X, but our membership is Y, and there seems to be a disparity. And I think it's a really hard thing to get. And ironically, I think we will know more because there are these mandatory national data sets which we have to fill in every month, are now beginning to record the presence of ALK fusion. So I think we will soon, probably the data will be out in 2025 or 6. I think we'll soon have an idea of the actual number of people with an ALK, and then you'll know how many people you're missing.
Thank you. Any other questions? I don't think there are. Oh, there's one over there. That's one.
No, that's okay. I was joking. I came all the way from Newcastle for this. You're going to get your money's worth.
I came all the way from
At least I hope you're going to get your money's worth.
Sorry. Yeah, I don't really know quite how to phrase my question. I'm still formulating it in my mind. But my oncologist a while ago said probably next year lorlatinib may become the first line of treatment. And I have to say I did question this and didn't fully understand why. So it would be great if you could kind of explain that, please. But also, should I be making an argument to switch to it? Or is it the case that, once you're on a drug and it's working, you should stay on that and try and get as much help as possible?
Yes, so for the arguments as to why we should have used lorlatinib first line, you should hear my talk from last year, which, is it available on the website?
It is.
Oh, there you go. Okay, and I'll send you my slides. I would never switch a drug when it was working because we don't know enough, and studies are all done in those hundreds of. And I had a patient who's had 8-9 years of ceritinib, which none of us now are using, and we heard somebody else earlier on who's on ceritinib long term. So everyone's cancer is different. I wouldn't switch if you're on a drug that you're tolerating well. I would stick. And going against my argument from last year, lorlatinib, we talked a little bit about it earlier. It's probably got more side effects than most of the drugs. It is a very good drug, which goes to the switch, particularly even in resistant disease. But I think you'll remember say this as well. It does have more side effects than some of the others do.
Yeah, it has got a license. It is one of the options, and it's one of the options because it's reasonable to do it. And I don't think anyone really knows what's the right or the wrong way of doing it. And I think if you are on...
Why didn't you say that last year?
I was just wanting to be mean. I think if you're on alectinib, brigatinib, and lorlatinib's been kept in reserve for later, it's a very, very, very reasonable thing to do. And if someone knows someone who's about to be started on first-line lorlatinib or in another country, they start on it, it's also a reasonable thing to do. But definitely don't switch drugs unless the first drug is not working. I absolutely agree with.
Right. I'm going to call time on this. I think both gentlemen did a superb job. And I'm delighted that it was a draw because we've got an excuse to bring them back again next year. But can we show our appreciation for both, please?